like, oh, like anything new.
June Advisory Board of Health meeting to order. If you could rise for the pledge, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. We have roll call, please.
Clink, present. Bulk,
Present.
Hayes,
Present.
Richards,
Present.
Smith,
Present.
Standell,
Here.
Urban.
Here.
And Madam Chair, I was wondering, since we don't have an addition or additions and deletions to the agenda, wondering if perhaps we could move the St. Clair County classification as a metropolitan county above the Title 10, being that that one is probably going to be pretty quick compared to our title. I imagine there's going to be a lot of public comment with that today. So I was wondering if we could do that.
Yeah, that's just a, there's no problem with that.
Okay, thank you.
Do you need a second or no?
I don't think we need a motion for
Okay.
that. It's just in order.
Thank you, Dawn.
Tammy, do we have citizens wishing to address the board? While we're waiting for that, I'd just like to remind everyone you have 3 minutes to speak. And just that everyone would be respectful of everyone else's. Vicky Blackburn, we'll start with you. It'd be followed by Eileen Tesh.
First, a public service announcement. I declined the RSV vaccine, so I've been dealing with RSV for a month, and I'm finally coming out the other end. So if anybody hasn't had their vaccine, I'm here to say, please do consider getting it. Okay, regarding today, we agreed that we don't want abortion rates to go up. Data shows us that as teen access to contraceptives decreases, abortion rates increase. So increasing teen pregnancy is counterproductive to decrease abortions. We know that the number of patients served at the health department will not be served by proposed medical residents. The McLaren residents may only practice 2.5 days per week, give or take. The health department may serve 1,500 to 2,000 patients per year, give or take. In 2013, the budget at the health department suffered a severe cut. And family planning services went downriver to the FQHC that is now called Community First. It did not work out. The health department was asked to take it back and did. If it didn't work then to outsource it, why would it work now? Second, we agree we want fiscal responsibility. Title 10 brings a lot of money to the health department. The department is able to bill insurance as well as use Title 10 funds. This brings in enough revenue to cover costs. The residence program is described on the website, Academic Center for Family Medicine. It states they are unable to take uninsured or underinsured patients. Where are they going to go to receive medical care? The plan proposed by Dr. Nubbin does not make sense for our community. I am concerned about continuity of care. I sent the chair, Ms. Standell, a list of concerns. It would be irresponsible for advisory board of health members to make Dr. Nubbin's motions at this time, even though he gave them to you in bold print, so you'd be sure to find them in that long packet. They owe it to the community to fact check the document he wrote, as there are said to be errors. To have any credibility in this moment, the advisory board of health must move to delay actions, including motions. Title X must remain at the health department to ensure health access for all of the residents in our community. This isn't just about you. This isn't just about me. We have access. It's about the people that can't get to these meetings. And frankly, this advisory board of health and the board of commissioners are making us literally sick.
Eileen, folks. After Eileen, Cheryl Scott, are you wanting to speak?
Good morning. I would just like to read a recent post from Michigan for Vaccine Choice. I've been involved with this organization over 20 years. As a family law attorney, I saw firsthand many cases, families with children with ADD, ADHD, autism. I have no children of my own, got my routine vaccines as a child. But when I spoke to these parents, many of them were convinced that it was a vaccine injury, which I had never heard of before. So the recent post from the Michigan for Vaccine Choice, Michigan MDHHS caves on vaccine tracking, but keeps harassing the parents. Under pressure, the health department finally made it easier to opt out of the MCIR tracking registry. Thank you, Dr. Nevin. But here's the real scandal. MDHHS spent millions developing an online waiver education module that forces parents to answer questions in a scripted way, compelling speech, while imposing illegal, burdensome education sessions designed to shame and deter families from using their lawful exemptions. Michigan law requires zero of this. No lectures, no privacy violations, no extra hoops, no compelled answers. Parents aren't the problem. Coercive government overreach is. And we've seen that firsthand. And again, I want to thank you, Dr. Nevin, for your work.
Cheryl, did you want to speak? Cheryl Smith? No, thank you. Liz, is it Siga? Thank you. And then that'll be followed by Angie Dufresne.
My name is Elizabeth Sigafus. I am a nurse practitioner with the St. Clair County Health Department. I'm here to respectfully ask that St. Clair County continue participating in the Title X Family Planning Program. I work part-time, 3 days each week, providing these family planning services, contraception counseling, STI testing and treatment, and preventative health, reproductive health care. During those 3 days, I meet people from every walk of life, young adults starting their careers, young parents working multiple jobs, and students trying to finish school, and families that are struggling to make ends meet. Title X exists to ensure that healthcare remains accessible to those who need it most. It is the nation's only federal program dedicated specifically to family planning and related preventative health services. It provides access to contraception, STI testing and treatment, cancer screenings, and preventative health care for individuals who may otherwise go without care. Across Michigan, thousands of residents rely on these services every year, and the majority are low-income individuals and families. As both a healthcare provider and a working mother, I understand the financial realities families face today. The cost of childcare alone can rival a mortgage payment, and add in doctor's appointments, school expenses, groceries, transportation, and rising housing costs, many families are stretched to their limits. Family planning is not simply about contraception. It is about giving people the ability to make informed decisions about when they are financially, emotionally, and physically prepared to have children. It allows families to plan responsibly and to provide stability for the children they already have. Every day, I help patients navigate some of the most important decisions of their lives. I help them prevent unintended pregnancies, access to treatment for sexually transmitted infections, and receive preventative health care they could otherwise not afford. These services improve health outcomes, they reduce healthcare costs, and they strengthen families. I love my job, and I love serving the residents of St. Clair County. I love helping people achieve their goals and protect their health and plan for their futures. Public health is about meeting people where they are and ensuring that access to care is not determined by income or circumstance. The mission of the St. Clair County Health Department is to prevent disease, promote healthy lifestyles, and protect the health of the people we serve. Continuing participation in Title X directly supports that mission by ensuring access to essential preventative healthcare for some of our county's most vulnerable residents. I respectfully ask this board to support the continuation of Title X funding and the vital services that it makes possible for the people of St. Clair County. I'd like to speak for those who cannot be here. Thank you for your time.
Thank you. After Angie will be Sherry Kuriko, right? Oh, there you are. Thank you.
Good morning, Angie Dufresne, Fort Gratiot, Michigan. I'm just here to support Dr. Nevin and what he is doing in our county. I think there's a lot of people that agree with me. I am coming from work. Luckily, my boss allowed me to leave to attend this meeting. I can't come to these meetings on a regular basis because I'm working. And I think there's a lot of people that agree with me that are working. I really would like to see this meeting pushed to a time when people that are working could actually attend, because I think that you have a very vocal minority in the county showing up to these meetings. And it's important to understand that a majority in this county, they're thankful for Dr. Nevin coming in and changing some of the things that have been going wrong in this county for a long time. I too have been involved with Michiganders for Vaccine Choice. I do not believe in vaccination at this point. I did when my kids were younger. We were all fully vaccinated. There was issues with that. Vaccines are not safe for everybody. And I think that what Dr. Nevin is doing is putting choice out there. He's not taking away the option for people to get vaccines. He's just giving choice so people are not forced to make a decision that they don't want to make. I also agree with his fluoride regulation. That's something that's impacted my health for over 13 years. And, you know, I'm a little frustrated at the amount of people that think it's okay to hurt some so that other people can have a benefit when they could take supplements to get the fluoride they want. It shouldn't be in our water. Our water should be free and clean of everything. We should not be ingesting something like fluoride. That's why you spit out the toothpaste. So I just came today to support what Dr. Nevin's doing. There's been a lot of hate thrown at him, and I want you to know there's a lot of us that agree with what he's doing. We just can't attend all the meetings. Thank you.
Thank you. Sherry, followed by Fred Fuller.
Hi, Sherry Mercurio, Clyde Township. I guess I'll just start by saying I know that the majority of the county does not agree with what Dr. Nevin's doing. But that across party lines, and I've been knocking on doors and asking, so I can tell you that's actually true of what I've experienced so far, and I'll keep you updated on that. I have some concerns about the Title X funding, and this is a little jumbled, so just bear with me. Patients using the program has risen every year for the last 3 years at this health department. Where's the evidence that county residents don't want this program? As someone else mentioned, it was cut at one time and given to somebody else who you're trying to give it to again. Didn't work out. Public demanded that it be brought back here. The public wanted it. So we need to see numbers. We need to understand where these claims are coming from. In footnote 12 of your memo, you mentioned that people can take advantage of the Take Control of Your Birth Control program through MDHHS. That ended in 2025. It's right there in your, if you go to what your footnote was, it says right in there, it's over with. So they can't do that. So we need a better understanding of where people are going to go. We need to know what discussions have been had with these outside entities, what they promised, what they're willing to do. We can't just stop a program based on Dr. Nevin saying, they'll probably take it. We can't do that. That's not how it works. You have to be, you're responsible for what's going on in this county. You're responsible for the public health system in this county. You can't just decide to shut something down without giving the public the evidence, the statistics, what we're gonna do next, who's gonna be harmed, who it's gonna affect. Dr. Nevin cites numbers in his memo that say that the program loses money. The public deserves to hear from the financial director. We should have a report. We should understand what is lost if we close this, what is gained by keeping it. We need the actual numbers. We need a list of every piece of this program that will be lost. It's a lot more than just birth control. It's a lot more than just, I saw a list online from somebody else. I haven't verified it, so I'm not gonna read it to you. It's long. It's a lot of things involved in this. When unplanned teen pregnancies rise, so do abortion rates, as someone else said. Teens are having unprotected sex, have a 90% chance of pregnancy within a year. 50% of teens will have sex before graduation. A third of those who become pregnant seek an abortion.
Ms. Mercurio, your time's up.
Thank you.
Thank you.
Fred, after Fred will be Rachel Bonelli.
Well, I agree with what Sherry said. The majority of people don't want what Dr. Nevin has been doing to this health department. In my opinion, he's trying to destroy it for his own political benefit, to make himself a name so that he can move on to something else in the circles of RFK Jr. So much of this makes no sense at all, like cutting Title X. Who's going to take the place of that? And a lot of the things that he cited in his memorandum aren't true. For instance, as Sherry mentioned, he cited that there was this MDHHS Take Control of Your Birth program that could pick up some of the slack, and that ended in December 2025. So I just don't understand. It makes no sense. Like Sherry said, we need a lot more information on the financial issues, how this would affect things. And I don't think I can say anything better than what the nurse practitioner said a little while ago. I thought we didn't have anybody that could do this when this other person retires, but it sounds like we do. And she made a great case for why this is a necessary program and necessary service to people in St. Clair County. It's about public health. It's not, I don't understand how the medical director, what role he has in this Title X. It's more about public health, not particularly about his work as the medical director in advising the health department. I guess that's all I've got to say. Hope you're listening. Thank you.
Thank you. Rachel, followed by Jimmy. I know I've got him.
Good morning. I fail to understand why Dr. Nevin, a community health professional, intends to abandon Title X. Title 10 Family Planning Program is the only domestic federal program and related services. It provides low or no cost services, and for many clients, it is their only source of health care and health education. State and local health departments are the home for these clinics, among other organizations. Many decades ago, I did not realize it at the time, but I was a beneficiary of Title 10. After high school, I worked in a restaurant to put myself through college, living at the poverty level. I went to my free clinic. I got a contraception. I was living with the man who I eventually married, and at the time, I did not plan to get pregnant, but rather planned to finish my degree. That is what family planning looks like. Family planning. Planning is something that is lacking here. I'm reminded of the closure of the school-based health clinics without a solid transition plan to serve students and families. We abandoned schools, and KPEC and Yale are left without a clinic. Suggesting an option that no longer exists, like the Take Control of Your Birth Control, indicates a lack of thorough investigation. The nearest Title 10 clinic is 25 miles away. Creating this burden indicates a lack of understanding about the access, what it looks like, with high gas prices, lack of robust public transportation, and many lacking vehicles. It's unreasonable. Preliminary discussions with trainees at McLaren about a possibility within the residency program was suggesting that an FQHC could step in to fill gaps or that other organizations could easily apply for Title X. It's not a plan. It's more like a hope and a prayer. Suggesting to purchase over-the-counter products is so tone deaf to the health department clients, of whom 80% are living at the poverty level with sky-high grocery prices and gas prices, is unrealistic. He fails to understand how people really live and what they can afford. Every effort should be made to stem infectious diseases like STIs. Dr. Nevin states the funding stream that supports these efforts is not appropriate. I would suggest he lobby Congress for changes instead of denying access to programs. I understand that there will be a staffing issue with the departure of the nurse practitioner. He states that his intention to hire a PA would be budgetarily irresponsible. Can the deputy be split so the new deputy can perform the contraceptive procedures? As a taxpayer, I don't support his priorities. If he cannot creatively solve the staffing issue by combining roles, perhaps he should put off the hire of a deputy to cover when he's out of the office and Canada on vacation. Title X has been successfully serving since 1970. There have been changes in the past years. Good leadership adapts to these changes and doesn't bail on cutting programs. Referencing Title X does not represent the community values. In my mind, our community values are compassion, respect, responsibility, collaboration, honest, fairness, kindness. How does providing STI screening, pregnancy testing, family planning service stand counter to these values? Irresponsible abandonment of community is counter to the values we hold. Dr. Nevin, first, do no harm, please.
Following Jimmy will be Patty Samar.
Good morning. My name is Jimmy Dotto, Port Huron. I'm here because I'm concerned about the continued reduction of public health services in our county, specifically Title X. Today, we're discussing family planning services, but this is about more than contraception. These programs provide pregnancy testing, cancer screenings, preventative care, and access to health care for residents who may not otherwise receive it. For many people, these services are not a convenience. They're a lifeline, okay? I keep hearing discussions about budgets, values, priorities. What I don't hear enough about are the people who rely on these services. When a service is eliminated, what happens to these residents who used it? Where do they go? How far must they travel? 25 miles, apparently. Thank you. Can they afford the alternative? Have we measured the impact before deciding these services are no longer necessary? Public health should not be evaluated solely by whether a service is profitable or politically popular. Hello, Nevin. Its purpose is to prevent illness, detect disease early, and keep people healthy before a crisis occurs. If the answer is that these services are no longer needed, then I would ask for the evidence. Show us the unmet need that has disappeared. Show us that the residents affected will have an equal access elsewhere. Show us that this decision improves health outcomes rather than diminishes them. This community has now watched outreach services reduced, clinics scaled back, preventative programs questioned, and public health resources repeatedly put on the chopping block. At some point, residents are justified in asking whether we are strengthening public health or slowly dismantling it. I just want to interject here at this point. Is it my understanding that we only have one OBGYN here in St. Clair County? Is that right? Yeah. Just want to put that out there. Because once these programs, staff, expertise, and resources are gone, rebuilding them is far more difficult than preserving them. The consequences are not felt in a budget spreadsheet. They are felt by the people who can no longer access this care. I ask the board to carefully consider whether reducing access to preventative health care is truly serving the people of St. Clair County. The role of public health is not to react after a crisis. It is to prevent the crisis from happening in the first place. I hope that the principle remains at the center of every discussion made here today. I've watched this board continually vote against what these people want, what is asked of you. You need to do better. Your elections are coming up.
Af- After Patty will be Dale. Amelia?
My name is Patty Samar. I am the editor and publisher of Blue Water Woman magazine. I care about women. Every woman in St. Clair County deserves safe, affordable, and convenient family planning, reproductive health care, and preventative health services. For decades, many have received those from Title X, which puts our federal tax dollars to good use, helping care for citizens in our county. Health departments across the state of Michigan and across the country make use of these available federal funds. This is our money. Good old boy Remy Nevin over here is prepared to discard almost $500,000 worth of Title X family planning money that is almost exclusively used by women. And I am pissed. I am pissed. Now, clearly, Remy and little Davy rushing over here and the rest of you Yahoo conservative men up there, you don't need to worry about contraceptives with your partners because I cannot imagine there is a woman or a man on this earth who would willingly want to have sex with any of you. Remy's data doesn't add up. He claims there is no need for these services. That is funny because per the St. Clair County Health Department annual reports, the number of patients served by family planning services increased by almost 200 patients from 2024 to 2025. Remy says it is not necessary for the county to provide these services because they are available elsewhere. I'm not sure where Remy is going for his gynecological exams, but our community lost at least 5 OBGYNs in the past 5 years. Women are already driving out of county for reproductive health care. And that is just the privileged women like me who have a car, can afford gas, and can actually leave the county. And let's just F over the socioeconomically depressed women in our community. Remy also stated that there is a staffing issue because the health department has lost some staff. Well, no shit, Sherlock. Per an investigation by your own St. Clair County Health Department, the Human Resources Department, excuse me, you have a documented sexist, misogynistic woman hater running roughshod over a department that employs primarily women and serves primarily women. Get rid of the misogynist and your staffing issues will go away. The role of the public health department is to provide safe and science-based research, public health services, not a la carte services based, willy-nilly on community values of a carpetbagger and a grifter named Remy Nevin. His community values are not my community values, nor any of these people's. Ever wonder why, if he is so wonderful, he doesn't have an actual full-time job as a physician somewhere? He's an outcast in his field and nobody wants him. Start leading like a government advisory board should. All of you so-called conservatives want smaller government. Start by recommending to the County Board of Commissioners that they fire Remy, and then by firing yourselves, you are dangerous and you are despicable. Thank you.
Dale, followed. Trey, were you speaking? Yeah.
My name's Dale Hemela. I live in Port Huron, 511 LaSalle Boulevard, and obviously have a hard time following my wife. I understand that Title X is under pressure from the 2027 budget that the president has put forward, and I really don't understand it. Although something that's been in place since 1970 with bipartisan support, being under pressure is just another indication of the misguided plans and, quite frankly, cruelty that this administration continues to put forward. Why you would want to cut Title X and why you would want to give back Title X money is beyond me. I don't understand it. But let me just say this. I'm retired, but during my working career, I spent a lot of time in West Virginia. And in fact, I spent a lot of time in McDowell County, West Virginia, which is consistently the least educated, poorest county in the United States. Not in West Virginia, but in the United States. And yet in McDowell County, they still have Title X available to residents for low cost or no cost health services for women and marginalized parts of the population. I would like to think that I live in a county that has a lot more on the ball than the least educated county in the United States, and yet it doesn't appear to be the case. If we turn back Title X money or decide that we don't want to take that for some reason, that boggles the mind, and it just, I don't understand it, and it's really hard for me to comprehend why we would do that to what we have in terms of services that we can provide, services that are very limited at this point, understanding that we can provide to people in our county, and in particular, a marginalized population. I hate to call women marginalized population, but that's where we are here in the country as it stands right now. So, thank you for your time. And oh, by the way, I just want to say, I'm 75 years old. I grew up with fluoride. I still have all my own teeth.
Good morning, and I wanted to thank you again for your support, support letter that came out from this board so that we can pursue what was the Moak Street project. And because of your support, I believe this board has done something that I think that is so super helpful to us as people that have challenges and problems. You gave us a path to go forward, figure out how my own responsibility to the problems I see can come together. This initiative is going to actually help a lot of people that have faith, that don't have faith, that are in different spheres of life without absolutely no government support, no agencies that have been funded accordingly, because we have found that there are ways in which we can take care of our own problems if we are given the opportunity. So I wanted to make sure that I thank you all and let you know the next step will be getting on the commissioner's agenda so that we can purchase the property accordingly with the funding that we are acquiring. Because what I have learned through listening just from the comments of this morning is that I have never been more happy or more proud, Liz, to be an African American or a pastor, because I have been a part of a group of people that have had the least amount of support from governments and or agencies throughout the years, and at one point was actually considered to be property and then turned into a person. And what we learned to do is, instead of begging government to have a conscience, we create our own answers. We take care of our own. All we need to do is figure out, are we willing to sweat and to make it happen? As a pastor, I am not a career pastor. I have stood with LGBTQ folks. I have stood with marginalized folk. I have stood with homeless folks, not because I was compensated to do so, but because it was on my heart to do so. And in that process, I've learned that there are two types of people in the world: people that will continue beg and beg and beg power to change their ways. And we realize power concedes nothing without a demand. Or we can say, let's go around power and let's just take care of our own. So I am extremely grateful for you all giving us this opportunity to show that Ronald Reagan was right, that when they say we're the government, we're here to help, is the most dangerous words that exist. The only way we can get past those words is admit that if we continue to give our responsibility and our ownership over to government, saying, please, please, government, expand your services, please, please do what we're too lazy to do, please, please, please help us, we will never get to the answers that will be sustainable for our own community and our own people. And I am proof that if we take the ownership of our own problems, we will need y'all. Thank you, guys.
Thank you. Nicole Castillo.
Hello, my name is Nicole Castillo. I'm a resident of Port Huron. Title X funding comes from the federal government. It is not county money. Ending family planning does not save the county a single dollar. Dr. Nevin has reportedly said this program doesn't comport with our values. I want to be clear what this means. This is not about money. This is not about health. This is about a personal belief system being imposed on the people of this county. Ending family planning means ending contraceptive counseling and birth control, IUDs, implants, and other long-acting contraception, STI and HIV testing and treatment, cervical and breast cancer screenings, pelvic exams, pregnancy testing and options counseling, infertility evaluations and referrals, preconception health assessments, and more. The people using these services are young people, people who cannot afford private doctors, working people, people who can't afford to take time off of work to come here and speak today. Without contraception, there will be unplanned pregnancies. Without STI testing, diseases spread. Without cancer screenings, women will die. There is no replacement plan. There is no financial justification. There is only a list of services that will no longer exist for the people who rely on them. Why end the program when it has funding? If you support this program, you are supporting to end reproductive health care for the poor in this county, the people you say you represent. Thank you.
Is there anyone else wishing to speak? Okay, we'll get you in a minute. And then your name?
My name is Carol Cataldo. I'm a lifelong St. Clair County resident. 30 years ago, I was newly divorced. I was working, so I didn't qualify for any of the Medicaid type programs they had. But I thought I was healthy until I discovered a lump in my left breast. My regular doctor had just retired, so I turned to Title X. This program was around since 1970, so it was very much around in the mid-90s when I was going through my crisis. The health department, with their breast screenings, allowed me to have the mammograms, the diagnosis, the eventual breast biopsy and lumpectomy, because it wasn't a cyst, it actually was a lump. And I have to thank Title X and St. Clair County Health Department for me standing here today, because without that program, in my opinion, I probably would not be standing here today. And it is my opinion, that is Dr. Niven's opinion, that the majority of us don't want this. And I really want to know where he gets those facts and figures when something that is very, very personal to me, and actually I believe from the bottom of my heart, saved my life, that it is unnecessary. So that's what I want to say to you, to the Board of Commissioners, that really think hard about discontinuing a program that there is no replacement for. Thank you.
Mark?
Thank you. Good morning. My name is Mark Smith, citizen of Birchville Township. I was hoping to get your attention without swearing or raising my voice, so I'm going to take all my clothes off. I appreciate you being here and listening in your public service. I have been, I guess, surprised and a little confused by a lot of the things I'm hearing. I am a conservative. I am a Republican. I'm a former elected official. I am a Christian. I am a Catholic. I'm anti-abortion. But Planned Parenthood and reproductive health planning is not abortion, and it's not an evil thing. Now, I understand if you're uncomfortable talking about sex or young women or unfortunately a lot of girls that are not even legal adults, let alone socially, developmentally adults, getting pregnant. But if you want to change that, you've got to educate them to prevent that in the future. I don't know if Dr. Remington would agree with me because he seems to be writing and reading instead of listening. I'm going to keep my clothes on though, don't worry. So it's just, I'm confused by the animosity and the tension between the groups here. I would like to believe that we all have the same goal, and that is the health of the people that are currently here. And if you want to change birth rates and sexually transmitted disease or whatever, you've got to, you do that for the future. For the people that are here now, they need services. Now, Dr. Remington, it's my understanding, is not the political director. He's not an administrative policy director. He is not the health department director. He is a medical director. And he should not be advising you. You are the advisory board. You are supposed to be advising him. You have a lot of sources of information in addition to Dr. Remington and others. I would hope that you do your homework and really think about what's good for the health of the current citizens in this county. Talking about reproduction and sex and a lot of social ills, that can be uncomfortable, but it's necessary. If you look at the reality of today, for years, and we still have people getting pregnant without planning it. Family planning is not pro-abortion. It's planning to prevent problems in the future. Taking away funding to help address some of the current issues is not going to help us solve the current issues today. If he wants to change policy, if he's politically motivated to enhance his image with Vermont or the state of Michigan or the Republican Party, that's his deal. But his job is to serve the public health of the citizens of St. Clair County. If you're not in favor of public health, then perhaps choose a different position. Thank you.
Is there anyone else wishing to speak? Okay, that'll close public comment. Looking for approval of the May 2026 minutes.
So moved.
There's support. Support. Been moved and seconded to approve the minutes of May 2026. Is there any further discussion? All in favor?
Aye.
Aye.
Opposed? Okay, correspondence, none, right?
No,
Was
there
that
there was none
Oh.
included.
Deb Johnson's?
I think we're saving that for under Dr. Nevin's report
Okay.
at this point. But there was some emails received early this morning or kind of later notice. So I believe, Tammy, were you able to send those out electronically
Yeah.
to the group? And then we'll move forward with figuring out with Civics Plus if that's part of the minutes next time or that's part of the correspondence at the next meeting. But you should have received those in your email.
this morning?
This,
Yes,
yeah, it
okay.
was.
Yes,
I
yeah,
didn't get a chance to see that. Thank you,
Yeah.
though.
sure. It was right before. It was about 8:45.
So
You're
we
probably already here.
received, yeah, we received correspondence from Jennifer Mahalik, Caitlin Ringett, Violet Phillips, a concerned citizen, and Kelly Baker.
Perfect, thank you.
Okay, unfinished business, Teen Health.
No real updates. Conversations continue there with Community First, with our nursing division moving forward. I believe that our nurse practitioner, verbally, I have confirmation at this point, not in writing, verbally, that our full-time nurse practitioner and our part-time clerk will be transitioning over to Community First. That leaves a full-time nursing coordinator who will have to be absorbed back at our main office. I'm still waiting for the in-writing resignations.
Thank you. And fluoride regulation, want to talk about the public hearing?
Yes, so you would have seen after discussions at our last meeting, we did schedule the public hearing for July 28th at 5:30 in the Board of Commissioners room. In-person comments on the proposed draft regulations will be heard at that time. Then there also is the option to email in your comments as well that will be shared.
Thank you. Any questions on that? All right, new business, Dr. Nevin. We'll start with the community mental health correspondence, then we'll do the metropolitan community, followed by Title 10.
Yeah, very good. And thank you, Madam Chair. So in your packet, you should see some correspondence exchanged between community mental health and the health department, following up on the discussed at last month's meeting, where we moved to discontinue our reliance on a contractor that largely engaged with members of the CSCB for our health priority setting. And I do appreciate the favorable motions received from members at the last meeting. I think that this exchange of correspondence has actually been very helpful in elaborating many of these longstanding issues with the governance of the CSCB, which had previously not been addressed. I was provided with a very helpful transcript of the CMH meeting that took place yesterday, and it appears that board members share many of the concerns that I articulated in my letter dated May 29th regarding the concentration of authority in CMH, some questions about some fiscal and fiduciary activities, and it appears that the CMH board is going to be looking into this, whether informally or formally. But the bottom line is, I think that this exchange of correspondence has been helpful. And I do want to point out a few brief sections of my letter, because as we discussed at the last meeting, the concern is not with the private organizations. Right? The concern is with the consolidation of authority. So for the record, I just want to say the following. I want to be clear that my concerns are not directed at the private charities, nonprofit organizations, faith-based groups, businesses, educational institutions, citizen representatives, or other community partners that participate in CSCB's work. My concerns are directed at the concentration of administrative authority, public resource support, and public policy influence within a CMH-administered structure that lacks ordinary public governance safeguards. And then later on in the letter, I say, the broader point is that collaboration is not the problem. The problem is the concentration of administrative control and public resource support in a structure that lacks ordinary public governance safeguards. CSCB's own documents and public statements present a body that claims exemption from OMA and FOIA, is not listed among the county's official boards and commissions, was never identified as having been constituted by the St. Clair County Board of Commissioners, requires nomination and dues for membership, is chaired, staffed, hosted, and fiscally administered by CMH, lacks conflict of interest rules in its MOU, and has no formal reporting obligation to any public body. And to bring it back to the point of interest, the role of this body and its members in setting health policy priorities for the health department, such a collaboration may be useful in other contexts while still being an inappropriate venue for health department priority setting. So I look forward to continued conversations with CMH and CSCB members. I've made it a point to attend all meetings and subcommittee meetings of the CSCB, and I anticipate doing so in the future. And as we discussed at the last meeting, I would encourage one or two members of the Health Advisory Board, ensuring that there's no quorum present, so you can't have 4 members present. But for example, this coming June 24 at 2 p.m., there is, well, excuse me, that is our remote chip session.
Yeah.
The next day, Thursday, June 25, is the steering committee meeting for the CSCB from noon till 1:30 at the CMH headquarters. So I would encourage at least 1 or 2 board members, you can decide amongst yourself, to attend, merely to observe and participate and add comments as may be appropriate. And then following up from that, because this is in advance of our next scheduled meeting, the CSCB Housing Work Group meeting is scheduled to meet July 8th, 1:30 to 3 p.m., location to be determined. So please make a note of those 2 dates, and if you can, please attend. I'm happy to have any further discussion or answer questions about this, what I think is very helpful correspondence between our
Can you just
organizations.
say, I'm sorry, the July 8th, what committee was that?
That is the Housing Work Group.
And it hasn't been set where it is.
When I last looked, there was no location, but CSCB has been very good. They've been increasingly good in response to this attention in posting information publicly. If you look at a snapshot of their website archived online, prior to my public comments, there was very little. And then after my public comments, you've seen this flood of information being posted. So all in all, I think very helpful, good progress being made towards increased transparency and governance improvements.
And what was the time for that meeting?
1:30,
1:30.
July 8th, yes.
Thank you.
Okay, so with that, if there are no questions on the correspondence, and we do have a slight revision to the order of the agenda, I assume by unanimous consent. So I would like to direct your attention to this map. I'll post it here for the cameras. You can see this is on the last page of your memo. This is something that came out either late last year or early this year, and I regret to say it eluded our county's notice. There was significant discussion about this in the legislature. If you look, the news discussed this, but they discussed this in the context of some counties down towards Detroit. These colors represent what the Michigan Department of Health and Human Services has labeled as rural or partly rural counties. And this is relevant because the Trump administration in its One Big Beautiful Bill has made a significant amount of funding available for rural counties. As my memo notes, more than $173 million are available to Michigan rural counties. This is just in the first tranche of funding, and significant additional funds are expected in the coming years. In Michigan, the funding works out to approximately $80 per rural resident. And in St. Clair County, with approximately 60,000 rural residents, if you do the arithmetic, you'll see it's just under $5 million of potential federal grant money, which is available to support rural health initiatives, but only if the county is deemed rural or semi-rural. And I hope everyone has noticed the very obvious discrepancy on this map. Wayne County and Oakland counties are, for some extraordinary reason, which I will discuss, considered semi-rural. And yet St. Clair County is considered metropolitan. This is an outrage. Now, fortunately, you have a medical director who's trained in preventive medicine and quantitative analysis, and who brings forth many years of policy experience and expertise. And so what this memo discusses is the reasons for this. It actually does make sense if you adopt the definition that the Michigan Department of Health and Human Services chose to use to define rural. And this is the federal definition, which is based upon census tract qualities. The bottom line is, I have repeated the analysis that MDHHS performed. And I regret to say they got their math right, according to the definition that the state voluntarily chose to use. And they didn't have to use this definition. according to the definition of rural that the state chose to use, we are a metropolitan county and Wayne and Oakland are semi-rural. And here's the reason why. Oakland contains one census tract that is a state park, 0 residents, therefore it is considered rural. Any county that has one census tract that is considered rural is deemed semi-rural. Wayne County has 2 census tracts that contain less than 100 people. One is a park, the other is the airport. And so Wayne County is considered semi-rural because it has a large airport. This makes no sense, and we should all be offended, particularly those who have spoken about the importance of keeping and bringing in federal funding. This is potentially $5 million that our county and our county's health agencies are losing because of this very obvious misclassification on the part of the state. Now, the reason why, despite the fact that we obviously have many census tracts that are decidedly rural in nature, the reason why the state considers those census tracts non-eligible for rural designation is because in those census tracts, each and every rural census tract in our county, there are over 30% of the population, hardworking, blue-collar people that get up every morning and they get in their car and they commute. They commute down 69, they commute down 94, and according to federal definitions, that renders them ineligible for a rural designation. So our hardworking, blue-collar workers are being punished because of their work ethic. If these were retirees who were sitting at home, or if these were white-collar workers, like the many thousands of staff at MDHHS that get to work from home, they would not be considered commuters, and they would be eligible potentially for a rural tract designation. So I hope that everyone shares in my frustration and my disappointment with MDHHS for adopting a definition of rural that very obviously benefits certain counties that have no rural character at the expense of counties like St. Clair and others like Monroe and others that have a decidedly rural character, and as we've heard today, that experience difficulties with access because of those problems. So the memo provides, I would like to think, sufficient detail for the Board of Commissioners and potentially our state and federal representatives to write a detailed letter in request to the appropriate agency heads at MDHHS and potentially also at HUD, right? Our federal representative may be able to intervene here. But this memo describes exactly the technical details, why this terrible discrepancy has occurred. And so now obviously it's not our place as a health advisory board to send up a formal resolution to these bodies, but perhaps after some discussion, perhaps after members ask some questions, we can sort out any residual uncertainty about this. I am recommending that the board recommend to the Board of Commissioners that they consider a resolution requesting reconsideration of this designation by MDHHS. There is still time for MDHHS to make adjustments to its funding formula. I believe it is possible with a determined effort on the part of our board and our elected representatives to get MDHHS to tweak its formula a little bit. For example, they could adopt a definition of rural similar to, I believe, what Oregon adopts, which defines ruralness based on typical rural characteristics, right? Difficulty in accessing healthcare, miles to education or healthcare institutions, rural density, which is what we used in our recent solar regulation. And I believe such a definition would result in a much more common sense definition of rural that would exclude obviously non-rural counties like Oakland and Wayne and include obviously semi-rural counties like St. Clair County. So I'm happy to take any questions. I would welcome a motion as described.
Dr. Nevin, when is the deadline that needs to be considered for that?
Well, there is no formal deadline. MDHHS has discretion that will continue, I believe, indefinitely into the future. Obviously, the sooner, the better. And I will admit, I missed this, right? One of the fundamental jobs of medical director with my training and my expertise in policy is to be aware of issues like this and to develop detailed memorandums like this that can help to inform much needed policy changes. And it never occurred to me in my wildest dreams that the state would have ever deemed us anything but metropolitan. I was vaguely aware that Wayne and Oakland had been deemed semi-rural. And so shame on me for not double checking the state's work at the time. That was back in December or January. It is now June. We're obviously 6 months late. But I think with a determined effort by our board and perhaps our state and federal representatives, I think we can effect this change. This captured lots of media attention back at the start of the year. And I believe that many people in the area would be rightly offended at this designation. This makes absolutely no sense. And it's depriving St. Clair County of potentially $5 million in much needing rural funding for important health initiatives, such as those that we will be discussing in the next agenda item.
Other comments?
Would changing this designation, I see in here, it says the Rural Health Transformation Program, and it'll unlock the potential. Does that mean these FQHCs would be eligible for these RHTP grants, like Bay
Yes.
County, like coming down?
But now potentially. So the eligibility of a particular facility at a particular location will depend upon many factors. And it's not necessarily the case that if we are classified as semi-rural by the state, that every single facility that may want to take advantage of these funds will gain access to it. But one thing is certain, if we are considered metropolitan, as we are currently, we are entitled to $0 from the federal government. So this must be changed. Now, I note in the final paragraph of this memo that our FQHCs, Community First, for whatever reason, and we do appreciate Community First's eagerness, and they have been very eager. I think perhaps they've wanted to do this for a while, to run our teen clinic and Algonac clinic. But they have said, Yale is too far. Logistically, it's too far for them. And so I think they are merely reinforcing the point that we had made previously, that it is not appropriate for an organization, largely based in Port Huron to run a facility that far away in the county. If Community First couldn't do it, then obviously we can't do it with a part-time medical director. Madam Chair, if we could have order, please.
Order, please.
Thank you. What I do note is that just across the St. Clair County border in Imlay City, Great Lakes Bay, a large federally qualified health center with dozens of small clinics all throughout the Thumb area, for whatever reason, they have not crossed the St. Clair County border. Now, I don't know why that is. It could be because for some time we had a clinic up there and they didn't want to tread on our turf, but certainly the absence of rural funding availability does not help an FQHC like Great Lakes Bay to decide to provide services in our neglected northern and western areas. So I'm hoping, I'm cautiously optimistic that revising this designation will unlock significant interest among private healthcare organizations to provide additional primary care services, particularly throughout our northern and western portions of the county, which are, of course, decidedly rural in nature.
Anything else?
I read through this and I found it preposterous that we are considered metropolitan. So I would actually move to support this recommendation and send it off to the Board of Commissioners.
Is there support?
I'll second that.
It's been moved and seconded to recommend that the St. Clair County Board of Commissioners consider adopting a resolution addressing the determination of metropolitan versus partially rural. Is there any further discussion? All those in favor?
Aye.
Opposed? That motion carries.
Thank you very much, members and Madam Chair. Okay, so now we're going to move to the topic of greatest interest. And before we begin, I trust everyone's had an opportunity to read this memo. As you know, this memo makes 6 mutually reinforcing and interrelated arguments in support of the policy change that is being considered. But I do want to note 2 minor errors which do not actually lend directly to the 4 arguments that underlie this recommendation. But for the record, I'll refer to footnote 12, as has been previously noted, the issue of the free distribution program. This program has no technical end date. The state stopped refilling supplies that are being distributed. But according to the state's website, this program does remain in operation in that the locations that are listed have not declared that their supplies are exhausted. And so it could very well be that the organizations who are listed simply haven't updated their listing, but I would imagine that many still have, for example, a box of condoms or potentially even some oral contraceptives. That point, however, is not primary to the reasoning behind my recommendations. So I will gladly concede a minor inconsistency in footnote 12, and I would ask the minutes be corrected to note that the program stopped resupplying supplies as of last year. And then I'll also direct your attention to footnotes, I believe it's 14, which describes an internal accounting of costs. And again, this is not a central argument in support of what I'm describing. We bring in around $300,000 in funding from this program. We're able to bill and receive direct insurance support of around $100,000 for a total of around $400,000, leaving the department with, because we have $500,000 in expenses, leaving us with approximately $100,000 deficit. I was informed after we had a meeting about the finances that, in fact, Medicaid does provide 90% cost reimbursement for otherwise unreimbursed costs. And so the question I asked was, well, if we bill another $100,000, can we get another $90,000 in Medicaid reimbursement? That's not clear to me, but I do want to correct a record that this program, although operating at a very minor loss, I think on the order of just a few $1,000s, this is perhaps not fiscally significant. We are I'm willing to concede that the program is potentially in the black or minimally in the red. The issue is not whether the program is operating on paper at a deficit or not. The issue is the cost effectiveness of this program. And so I'm going to get into the issue of cost effectiveness in my discussion of the other points. And again, this memo, and I encourage everyone who's in attendance and who's been helpful enough to share their comments to ensure you read the memo in full, because there are numerous reasons why this issue is coming to a head now and needs to be decided. And the first point is the fact that we are facing a staffing decision. And I do appreciate our part-time nurse practitioner who's been willing to provide these services outside of what she was originally hired for. We are delighted to have her, and I do appreciate her staying on to provide these services. However, I question whether the MDHHS Title X program would accept this program continuing into the future with only part-time staffing. We previously had a full-time FTE devoted to nothing but Title X service provision. And so this would be a significant deviation from prior practices. In order for us to get back to where we were at the start of this current grant cycle, we would need to advertise, review, hire, and potentially train a nurse practitioner or a PA with experience and interest in performing primarily Title X services. Within the backdrop of the controversy and funding uncertainty and programmatic uncertainty that I'm going to be discussing, my impression is that if we were to elect to continue with Title X grant funding for the coming fiscal year, operationally, we would find it challenging to find a qualified provider. And I would have concerns with bringing them on with the expectation that in due course, they would be let go as we again reconsider this program amidst the uncertainties and volatility that I'm going to be discussing in a future section. There's also the issue of the deputy medical director position that we had previously discussed. If I had a choice between hiring one clinician full-time in the coming months, I would as medical director, wish to prioritize the deputy position for the reasons that we've already described and that has been voted on and supported. All right, moving on to point 2. I was a family practice intern at Fort Bragg. We had 3 chief complaints. I'm pregnant, I'm about to have a baby, I broke my ankle, and I have an STD. So those were the 3 most common chief complaints that we had at our clinic. I think it's a little different up at McLaren, but the residents tell me that they are short procedures. Now, it's absolutely essential when family practice residents, trainees, are taking part in their training that they have access to a patient population that provides them the training opportunities that will allow them to go out and practice in the community to the level expected of them. We've heard from many folks that are concerned about the lack of obstetrical and gynecological care in the community. I share those concerns. And so the solution to that is to ensure that our family practice residents, our trainees in the area, many of whom have committed to staying in this area, have access to training opportunities that will permit them to become competent clinicians, able to insert and remove IUDs, able to insert and remove Nexplanon, able to counsel patients appropriately on the use of both short and longer lasting contraceptives. And currently, the available patient population, I think, is not optimal for them. Now, there are logistical details to be arranged, but no differently than dental schools will often see indigent, uninsured patients for the benefit of increasing access to training opportunities. I'm confident that the department and McLaren can work together to resolve these issues. I would propose that the department can defer those details to its own authority in due course. Third, we've heard from many residents concerned with the availability of contraceptives absent a Title X program. But the fact is the contraceptive landscape has changed significantly since the Title X program was conceived of by the federal government. If the legislators that conceived of Title X and originally funded it were aware that you could just go to the drugstore and buy oral daily contraceptives, I question whether there would have been as much support for the program, because the primary motivation for the program initially was to make available these essentially daily pills, which are now available over the counter. I bought this at CVS this morning on the way here. It was $20, and I recognize $20 is a lot for many people. Madam
Guys,
Chair,
point of order, please.
Folks.
Thank you. So I realize $20 may seem like a lot to folks. However, as I've discussed in this memo, when we look at the per patient or per encounter cost of providing what in many cases is just this, right, or condoms. 1/3 of our encounters consist of prescribing or dispensing condoms, which are ubiquitous and freely available in many places, or daily contraceptives, which are low cost and again, freely, ubiquitously available throughout the county. So fully 1/3 of our budget of $500,000 is devoted primarily to encounters that consist in its reproductive component of dispensing contraceptives that are readily available over the counter. And if we calculate what the per encounter cost is across this program, we spend approximately $500,000 on this program, and we see under 1,000 unduplicated patients. Let's make the math easy. Let's say we see 1,000 patients, right? So that is how much money per patient? That's $500 per unduplicated patient we see. And if 1/3 of those patients are fundamentally, from a reproductive perspective, only getting something that can be purchased at the store for $20, this is not a cost-efficient use of funding for the reproductive services that are at issue. It's not. Now, we've heard several comments about STD care. STI care is a core function of local health departments. The prevention of syphilis, gonorrhea, treatment of chlamydia, these are core public health services, and they will continue regardless of what decision we make on the Title X program. Now, it is perhaps an open secret in Michigan that MDHHS prefers that local health departments apply for and receive Title X funding to cross-subsidize the core STD prevention and treatment services. that all health departments are required to participate in. But I believe that this is a very unwise fiscal foundation on which to base the.
Sir,
Fred,
Fred.
folks, hey, we need to have decorum, please.
Thank you, Madam Chair. For reestablishing order. So as I described in another section, this funding, this very high per patient cost, which is at least $500, and in many cases is above what can be reasonably defended on the basis of what services are provided. In addition to tying ourselves to this particular funding stream, we are also accepting the program requirements that come with Title X programs. Now, I want to direct your attention to the 5th paragraph where I describe the governing regulation 42 CFR 5910B, which provides that Title X projects may not require consent of parents or guardians for the provision of services to minors. So what this means functionally is that unlike every other healthcare service that we provide, with the exception of a small number related to STI care, we are prohibited from telling the parent, for example, that a 14-year-old has come requesting an IUD. Prohibited. We can't tell the parent. Now, this directly conflicts with Michigan law. That provision directly conflicts with Michigan law that permits me as a provider to determine based on my clinical judgment or the clinical judgment of our NP whether informing the parent of this request would be beneficial. There are obviously times when confidentiality is potentially wise, but this ties our hands. We are unable to tell the parent. And I believe that this particular provision is incompatible with the dominant majority values of our county.
Please stop. Please stop outburst till you be asked to leave.
Now, those confidentiality requirements are longstanding in Title X. What is new are the ever-shifting and increasingly partisan and politicized requirements that now ride upon Title X grants with every change in federal administration. We are aware that several years ago now, of course, for broader context, we are discussing one healthcare organization contemplating discontinuing Title X activities. This is nothing new in Michigan. Across Michigan.
Stop.
Ladies and gentlemen, we're going to postpone if we keep this up. Please, please. Motion to adjourn for 10 minutes until the crowd calms down.
Support it. Support.
Support.
All those in favor?
Aye.
So, Madam Chair, to clarify, we have a recess for 10 minutes.
We're going to recess for, yes, 10 minutes.
Meeting back to order. If everyone could take their seats, please. If we could please stop the side conversations so we can get back to order. Thank you. Dr. Nevin.
Well, thank you, Madam Chair. So I believe I was discussing that healthcare organizations discontinuing their involvement in Title X is nothing new. And here in Michigan and across the country, we know, for example, Planned Parenthood elected to discontinue their involvement with Title X precisely because of what they viewed as unreasonable requirements associated with the grant program, which are very volatile and subject to increasingly wide and wild shifts with every change in federal administration. Presumably, there was support among supporters of those organizations for discontinuing Title X funding. What the county and members of the board should be aware of is that there are legitimate questions about the near-term sustainability of this funding. The fiscal year 27 notice of funding opportunity, which has been released by HHS, radically transforms Title X, largely in support of the agenda of the HHS secretary. Now, if the advisory board and if county residents want the medical director to enthusiastically support and implement a program which has been redesigned by HHS to advance MAHA objectives, we can certainly have that discussion. But my strong recommendation is that we do not take HHS up on their offer. If you're not familiar with the new pending requirements of the revised Title X grant funding, they include ending diversity, equity, and inclusion policies and practices across the program to the extent allowed by law, ensure that federal resources are not used to facilitate or incentivize illegal immigration. There are a number of other interpretations and nuances in this program, but it's clear that new Title X funding will be contingent on grant recipients engaging in activities that are radically different than what they are currently. Title X has become a political hot potato that introduces previously unseen volatility. We've seen wild swings in organizations' willingness to accept Title X funding, depending on whether year by year it aligns with their particular political perspectives or priorities. And I expect this will continue into the future. There's also a legitimate question of whether MDHHS will, as the primary grant recipient from which we as a subrecipient receive funds, if they will even accept this funding. It would require MDHHS to accept a number of requirements that are distinctly at odds with their preferences. Now, I would say odds are they probably will. But for the first time, I think it is a distinct possibility that they may not accept this funding, which means this funding may plausibly come to an end. But more importantly, I think with these recent changes, Title X has now passed the point at which a responsible medical director and local health department can plan on this funding to be the foundation for its core STI control mission. I believe that we must extricate those activities from this increasingly volatile, unreliable, likely to be litigated program and provide our core STI treatment and prevention services with other grant funding streams and with core funding. It does not take $500,000 and 5 FTE to meet the core statutory and regulatory requirements for us to control STDs. When I was in the military, we did this with a skeleton staff and we did it very well. And likewise here, I believe we can similarly provide those core services in a much more cost-effective manner while freeing up the market for contraceptive services to a private provider such as an FQHC who may then have the demand to justify stable funding from. Madam Chair, if I could have order, please.
Folks, Please stop interrupting.
And Madam Chair, I need to make something clear. The decisions at issue here are largely within my purview, right? The hiring and oversight of the necessary nurse practitioner, that's entirely within my purview. If we do not have the opportunity today to discuss these issues publicly without interruption, if we as a Health Advisory Board are not able to deliberate this issue without interruption, I'm going to make a decision on this within my own authority. My preference would be that we do this publicly and have an opportunity to deliberate. And I should clarify, there is no other opportunity to have this discussion. With scheduling matters as they are, we must come to a decision on this today. I asked the chair to prioritize this issue for discussion today. Logistically, we must arrive at a plan today. And so I trust that we will not have any more interruptions that might prevent us from deliberating on this as is desirable. All right, so we've discussed the fact that many other healthcare organizations, even in Michigan, have elected to discontinue Title X funding because it does not align with their values. We have determined that these services, to the extent that they largely replicate reproductive health care that can be obtained at lower cost through other mechanisms, is not cost effective. Whether or not it's cost neutral to the department is incidental to my recommendation. But it is decidedly cost ineffective on a population level. Now I want to get to the core point. And the core point is that although contraceptive services are described by some as public health, pregnancy is not a sexually transmitted disease that public health departments are required by the Public Health Code to prevent. There is a decided difference between a case of syphilis, gonorrhea, or chlamydia, which is universally undesirable and which must be prevented and treated, and pregnancy, the choice of which is optional and is something best left to an individual's primary care provider and not the county's public health agency. We are not primarily a clinical organization, right? There is a very limited role for clinical services to the extent that that's necessary to control public health threats to the population. But we are not primarily intended to be a clinical services provider. We've had this discussion before, right? In the context of whether we as a health department should be running a network of primary care clinics. And the overwhelming decision from that was that, no, this is a service that is best performed by federally qualified health centers and other primary care organizations to allow the health department to focus on those things that only the health department can do, right? There are many other organizations that can provide contraceptive services. There are many other organizations that can provide primary care. There are many other organizations that can provide cancer screenings, colonoscopies, for example, skin cancer screenings. Madam Chair, I would ask for order, please. Thank you. But there's only one organization that can provide the assessment, education, oversight, regulation, and ensure compliance with the Public Health Code, and that's us. Every minute, every hour, every day that we spend discussing primary care services is time that we don't spend focusing on our core statutory public health mission. So it's not surprising that across Michigan, this is not uncommon, that public health bodies, that local health departments choose not to provide any optional contraceptive services. And you can see in paragraph 6 that in Michigan, Barry Eaton Health Department, Branch Hillsdale St. Joseph Health Department, Allegan, and Muskegon County provide no contraceptive services whatsoever. Why? Because it's not a public health service, according to the Public Health Code. They're not required to. Many people would be surprised that among other local health departments in the county, based on the best available evidence, I did significant search, and I believe I'm correct, although I'm happy to be corrected if I'm wrong. I do not see evidence of Title X funding for the health departments in Ionia County, Jackson, Kent, Lapeer, Oakland, or Wayne County. So this is not at all unusual for a local health department to elect not to participate in Title X funding. And I reference in the memo the overarching statute and the MDHHS standards manual that says very clearly local health departments may but are not required to provide family planning services under supervision of MDHHS. The only statutory requirement is that we publicize the availability of family planning services. So if we say there's a Title X clinic located here, that meets our statutory requirement. So those 6 reasons, again, I'll emphasize, my recommendations and the primary rationale behind each of those 6 points do not depend upon the factual issues that we corrected for the record. They largely each stand on their own, but taken together, they're mutually reinforcing. And unfortunately, circumstances call for a decision to be made on this issue. The program is not going to run itself. It needs medical supervision. It needs a full-time clinician that needs to be hired and trained. And our prioritizing those actions will be at the expense of what I believe has been the advisory board's priorities of refocusing our activities on our core public health services. So the decision before us today, if I may welcome such a motion, would be to address the question of whether we reapply for Title X funding. That's really the only question that I am asking the board to address today. Operational issues, such as whether we continue with some modest level of these services, funding and staffing available, what discussions we have with potential partner organizations in facilitating the transfer of these services, and how we deal with the logistics of this transformation. I would propose this can be addressed within the department itself. The primary question is, and which will govern actions going forward, is do we reapply for this funding? And my very strong recommendation, for the reasons I've described, is that we do not.
Are you finished?
Yes. Thank you, Madam Chair.
Are there questions from the board?
I have one, Monica.
Go ahead.
With this, in order to have a discussion, do we have to make a motion to
No.
have a discussion? Okay, thank you.
That's your question?
Yes, that is my question.
Okay.
I have other questions, but
Okay.
I wanted to make sure that I
Yeah.
could ask the questions
You can
or
ask
make
the question.
statements before we had, if we had to make a motion first.
No.
Okay,
We can discuss the topic.
so a couple questions. I'm not sure who is best suited to this question, whether it's Liz, Dr. Nevin, Amy, or Rebecca.
So
Um,
staff is prepared.
Okay.
Here, we knew this would be a topic
Right.
to answer your questions. If I can't answer them, Amy would be best programmatically. There, Jeff is here on finances. Greg and I can also answer financial things, grant questions, those as well. So
These would be more nursing questions.
So I would
Liz,
ask
Amy, or
that Amy and Rebecca answer those.
Um,
Madam Chair, we should have a unanimous consent for a change to the agenda to permit speakers not on the agenda. I'm sure the members would approve.
They're not prepared. They're not gonna do a PowerPoint or anything like that. They're there to answer your questions. Yeah.
I don't believe a motion is in order.
So, multiple questions. One, how many cancer screenings does the St. Clair County Health Department currently do? That was not listed
I
in.
did not bring a complete set of data, but I believe around 100 in 2025.
One of the,
And that's
and
pap
that's per
screenings.
year.
That's pap smears. That
So,
doesn't
but you're
include,
not
like, breast
including,
Screening and that kind of thing.
and that does not include breast screening. just
No,
pap
I don't
smears.
have that information in front of me. I can certainly write it down and provide it for you late at a later date.
So would that be about similar to past years?
I don't have the information in front of me, so didn't anticipate that question.
Well,
The practitioners as well, or men, will also do visual examinations of the penis and anus for any obvious lumps or questionable items there for cancer as well.
do they also do prostate exams, even though they're young people?
Not to my knowledge.
I'm not sure.
How many fertility evaluations does the St. Clair County Health Department currently do?
On females, that's.
Yeah, like PCOS or other things like that, since that was listed as one of the potential Title 10 as one of the recommendations on page 3, I believe it was, that Title 10 does for the funding for 2027.
There is a set of questions that is asked for the majority of women seeking services under family planning that include any barriers or risk to conception. And I would
Included in the
imagine,
screening questions.
yeah, the provider would use like a shared clinical decision-making and client-centered approach, asking deeper questions too. If a woman is experiencing maybe inability to conceive, things of that nature, conversations would be guided based on those conversations and the question.
Once those evals are done, how is that client then referred out?
So we refer clients to either local place. So of course, North Point sees OB and GYN clients. Dr. Bailey's office will see GYN only clients. So we will attempt to get them somewhere locally. And then if we're not able to do that, we will refer them to places out of county.
And out of the 100 Title 10, or out of the 100 cancer screenings, how many are Title
Pap
10?
smears.
Pap smears. How many are Title 10, do you think?
All of them.
All of them? Okay. With the fertility evals, are you guys able to get people into further care, or how do you take care of them?
That's
then?
always, absolutely, that can be difficult in our county as mentioned, but we definitely do manage fertility concerns, even if it's referral.
Where else does St. Clair County get its family planning money from, other than Title 10? Because there are other funding options. I didn't know if St. Clair County looks for those counties.
Title 10,
Just
100% Title 10 funding for that program.
Okay.
In addition, you know, we can break it down to billing and those kind of things come in, but no other funding. Yeah, right. So our Medicaid reimbursement, our private insurance billing, our Medicaid insurance, and then the grant, but no additional grants.
Okay.
There.
In the information Dr. Nevin provided, it did show that there has been an increase generally in usage for the number of female clients since 2027 or 2017, sorry. But I also noted that with that, for public funding, so that would be Medicaid funding, 51%. I'm guessing that's 51% of your clients were Medicaid funded.
Yes.
Does that mean you get does that mean those clients' care is paid through Medicaid versus Title 10 funding?
Yes, so we
Right, yeah,
would
so we can
receive
bill.
reimbursement and be able to bill for those services.
Okay.
And we accept Medicaid. At other providers locally, they do not accept Medicaid unless you are pregnant, so.
And I want to, if you're trying to understand funding and if potentially maybe could we see them without the Title $10, I think a lot of the support we got is the Medicaid reimbursement funds and dollars, which is very complicated, but Jeff is here on the back end. So remember, as a health department, we are allowed, not only do we bill Medicaid, get that rate, on the back end, we get supplemental funding that brings that up to a private pay amount.
So with that also being said, it says 64% are below poverty for your clientele, correct? So that means that 64% of the clients for St. Clair County have Medicaid or are eligible for Medicaid if they don't have it.
Or uninsured.
Some are uninsured or underinsured, so either not eligible for Medicaid for whatever reason, or are on a Medicaid spend down.
So one of the questions I also have has to do with contraception. As of July 1st, MDHHS has the new policy that pharmacies can prescribe with a self-screening, basically. They can prescribe patches, oral contraception, and vaginal maneuverings, basically. How do you foresee that changing your numbers? And if you do, would you be able to make your Title X funding quotas?
So that's if the pharmacists participate in that.
I do know Walmart will be, they had a sign posting it.
Yeah, so when the Take Control of Your Birth Control campaign came out as well, pharmacies, I don't know if it was in conjunction with that plan or part of that plan, we're doing that as well. And I know I had the curiosity's sake gone onto the Walmart pharmacy website, and it was pretty simple. And a conversation Amy and I had at that time too was exactly that. Will this reduce our caseload? And it did not at all. And in fact, we have seen increasing numbers.
But that program doesn't actually go into effect till July 1st, 2026, which is in 16 days
So.
or 15
Correct,
days.
but there was with the Take Control of Your Birth Control, and like Dr. Nevin pointed out, where you could go and get the over-the-counter options. You know, we were concerned that these increase of accessibility would negatively impact our clients and services that we saw, but it did not.
I think that's it for the moment. I do have a couple other questions, but I will wait to see.
I just want to clarify. So your fertility screening is just questions? Like it's just questioning?
Screening questions up front, yes, and interview of the client.
No blood work, no exam or anything like that?
Again, that would be up to the provider's discretion at that point. If, you know, based on the screening questions, they did determine that there was an increased need for other things. I think more often they are referred out to an OBGYN physician who is able to manage their complete care at that time.
And as far as the breast screenings, the lady mentioned that she was able to get mammograms and stuff. Does Title IX include mammograms?
It does not, but we link them up with the breast cancer screening. There's a specific program that covers those tests. So we work together. It's another state or federal program that
Outside of Title IX.
outside of Title X.
Would the health department still continue to do that whether or not they had Title X funding? If someone came in and said, hey, I think I have a problem?
Of course, we could refer to someone else, absolutely, and see if they qualify. But we wouldn't be able to screen them or, you know, see them clinically if we don't have orders to do so.
Does the People's Clinic assist you with some of those referrals?
I'm sure they would. I mean, they're still gonna work with the breast cancer screening, colon cancer screening program to cover the cost of the test because those are done at the hospital.
I was just kind of going down the line, so, Steve, do you have any?
Answer.
Okay.
Me too.
I have a few. The funding, as I understood these grants, a lot of these are rollover grants, so we don't actually physically reapply for this grant, do we?
Correct. Right. So similar to when we discussed adolescent health, there was an original grant application that I actually did write for in 2016 when the program came back. Very much involved, large grant. What happens then is we have continuation funding. We have case numbers that need to be met. We have work plans. We have projects, other indicators that need to be met, discussed, but no large grant that needs to be written. We would just, we would decline the funding there within Jeff's world and not accept the funding. But the funding is keyed in for St. Clair County at this point.
Okay. So whether this decision was made today or after doing more research into this or trying to find another partner first, we could discontinue, if that were the choice, after we found another suitable partner, because the grant is set. We could stop it at any time.
Well, yes and no.
Okay.
It's set, and we can go ahead and accept it. The budget preparation has to be done prior to September 1
Correct.
for the county and the state. So we need to act on it before the last day of September.
Correct. Okay, so I understand that part for staffing purposes. So that leads me to my next question of what is the staffing implication? How many people are going to lose jobs over this?
Several. Again, preliminarily have been looking at our current staffing, and with the elimination of these funds from nursing division alone, at least 5 staff would likely be put on layoff, and then health department wide, at least another 3 that I conservatively was estimating.
So to tie on to that, so as the funding for Title X does primarily pay for your direct care providers that are there. So when we budget, that is a nurse practitioner, that there's an RN, there's a tech, there's clerks that support that program. But you have to think outside of that, right? The trickle effect. There's a lot of billing being reduced. There is other dollars, education, outreach, promotion, those kind of things that as myself, looking at the big picture, that's there as well.
So Madam Chair, if I could add some further context. So I believe what we've heard is that substantial proportion of our patients do have insurance and they are eligible to be seen in the community. To the extent that we are providing these services here, we are cannibalizing the market for these services that could subsidize private providers in the community. And when we talk about staffing allocations and so forth, we have to recognize that if services are provided here or if they are provided in the community with available insurance funds, there is still a demand for those nursing staff. It would just be a relocation of nursing staff from a potentially very inefficient use of those staff here at the health department to a more efficient use elsewhere. Madam Chair, if we could have order, please.
Continue, Dr. Nevin.
Yeah, thank you. Thank you very much. Now,
Could I say something on that point, Dr. Nevin? Would you mind?
Liz, if you don't mind, if I could just continue my point. So we've seen that the provision of these services, which are not core to public health, right? And as we've established, do appear to be available to a majority of our patients elsewhere in the community. This results in excessive staffing duplication. We must build an infrastructure at the health department that is largely clinical, is not focused on our primary public health priorities, and that money that we spend here more inefficiently than the private sector, because we are a government and governments always spend money more inefficiently than the private sector. This results in that money not being available to the private sector to provide not only these services, but other more expansive primary care services. Every patient that we can relocate from our health department to an FQHC or to a primary provider who's accepting Medicaid can not only access these limited services, but the full range of primary care services, which are necessary for health.
Liz, you wanted to comment?
Yeah, I think as far as just providers in the community, I want to point out, certainly if we didn't have the program, our Medicaid clients, our insured clients could seek these services other places. However, my understanding is there's offices, limited availability for Medicaid patients, GYN patients. Is that correct?
Correct. And just anecdotally to share a story of a staff member, she had called North Point for GYN care. She was looking to have a conversation, an appointment regarding birth control. And she ended up just scheduling within our family planning clinic and got her services, within the few days. And just last week, which was 3 months from her initial phone call and voicemail left at North Point, they called her back asking if she was wanting to schedule with them.
Right. And not to speak for a private provider in the community who runs their own business, I think it would be best served for them to speak. But my understanding is that we are privy to 340B pricing, correct? Which is a pricing, reduced pricing when we purchase supplies, when we purchase IUDs, when we purchase Nexplanons, that is much lower than private provider is going to see. And then they're going to get a reduced rate on that Medicaid billing. So they're buying their supplies at a higher rate. They are getting less reimbursement when they bill, and they are not getting that back end that we do. So I understand what Dr. Nevin is trying to say is perhaps someone could find these services in the community. I don't know that it's that advantageous for a lot of our providers, and maybe why there is limited access. And perhaps they could go to Walmart at that point if they're not using IUDs or a LARC or Nexplanon, potentially.
So a couple interesting things I think about public health in general. One, and pardon me for those that have heard me say this already, is a fatal flaw within public health is that the outcomes are not always measurable because we do focus on prevention. And so you do not hear or see the things that didn't happen. You're not seeing the, fetal demise, those things. So I think it's our own Achilles heel in a way to say, oh, these services are not needed because we're not having a high incidence of whatever it might be in the Title X family planning world. Secondly, more than one Title X provider can exist in a county. So we are not taking funds from other entities. If they wanted to, they could. And next, public health does exist to fill a gap. And if there wasn't a need in the county, we would not see the caseload of clients that we do.
Yeah, so, okay. Which brings me full circle to our caseload. We currently see about 870, 871, I think, okay. Unduplicated patients.
Correct. So these clients may have more than one visit.
Right. But 871 are unduplicated.
Yes.
Okay. My problem with this in not accepting these funds are, while it's great to say they can go to Walmart, Walmart can't provide the services that a lot of these folks are looking for, right? They're not going to be able to do IUDs or what's the other one next? Yeah, next one. And so, do we know how many clients use those?
So Madam Chair, if you look on
Do I-
figure 8, you'll see that data.
140? It's in the pie chart somewhere.
It is.
Yeah. I don't see these services being readily available in the community through other agencies. Community First gave this up. They had the grant after we had to discontinue the grant at one point and weren't able to fulfill it. And there was no Title X services in the county without us taking it back. And so I think it would be irresponsible of us to discontinue this. We do not have adequate OBGYN coverage in this county. It's been something that this board has discussed. We don't have the ability to bring physicians into the county. However, stopping services that aren't readily available otherwise, I don't see it as, if the federal government chooses through their reallocation of funds to not fund the program, then we would deal with that accordingly, I would assume. But just for us to randomly decide that we are not going to accept these funds for obviously very needed funds and utilized funds, I think just is reckless.
Madam Chair, if I could address those characterizations. So this is not random. I have articulated 6 mutually reinforcing reasons why a decision of this nature is necessary now. We must decide essentially today what our staff hiring priorities will be. We are already behind the ball on that. We cannot delay any further. We must decide whether we hire a full-time nurse practitioner, against tremendous difficulty, I might add, to provide these services full-time on an ongoing basis, as will be considered required for continued Title X eligibility, or whether we proceed with the recommendation that the Health Advisory Board had made previously to refocus our clinical activities towards our core statutory services. That's the decision before us imminently, upon which action will be taken one way or another, regardless of the decision today. We have seen that a significant number of the patients that we see under this program are able to be seen elsewhere. And we've also seen that there is a critical need to train new providers we have seen that there is a critical need to provide training opportunities to the doctors who will become tomorrow's OB-GYN providers. Currently, they do not have access to a sufficient volume of procedures in order to become as competent as we would like them to be. So a number of factors, I believe, weigh strongly against our reapplying for this funding. This does not preclude our transitioning in a deliberate manner out of providing these services, but a decision of this nature today would ensure that we are not held to continued Title X standards, which may not be reasonable going forward, which may bind us to do things which are not aligned with our priorities, and as we've seen, are not essential to provide a limited number of these services in a manner that we decide to provide ourselves.
And while I understand some of the points that you make, I don't necessarily agree with them all, but I also feel it is the McLaren physicians are seeing patients. And I guess I would like to know from them specifically that they don't have enough patients. And I don't know that our patients would choose to go there. That's not saying just because we discontinue that those patients are automatically going to flow into that program. And maybe there is a way to work together in conjunction with that program, but I don't know that we've investigated that. I think this is a haphazard way of just getting rid of this program. And again, I don't think it's a responsible way to go about it. I can get on board with the health department scaling down to core function if I know that the services are being provided in another manner, such as the teen health clinic. I did not support that program being closed. However, I did support working with finding a community partner, which we did, and that has worked out. Now, did it work out for Yale and KPAC? Absolutely not. But it did work out for the Port Huron Clinic, and that I hope will be a good partnership for them and for Algonac and continuing those services. But to just stop this program, again, just pulling the wool out from under, or the floor out from underneath the program, is not responsible, in my opinion. I don't. Paul, did you have comments? I'm sorry.
No, you're good.
No.
No, I think for me, I look at, kind of a lot of what you had just said too. The dollars do have to make sense, but at the end of the day, I've always been of the mindset, if we're going to take services away, we have to provide them, and we have to find a means to do that. I'm not satisfied that we have actually done that, because there is a lot at stake. There's a lot of data with all of this that has not even been vetted. It just hasn't. And making a decision like this is a little, I think, preemptive to do, not knowing the ramifications.
I have a quick question.
So, sorry.
Were you gonna?
I was just wondering, in reading through this information, it stated that part of this may not require consent of parents. Are there certain parts that do require and certain parts that don't?
So unfortunately, under Title 10, all encounters are confidential, regardless of the age of the child.
That's not accurate. That's not how we define that. Confidential would mean minors, and that is less than 2% of our clientele right now. I did look at it.
Well, Madam Chair, that's precisely the point. Title 10 requirements, we are obligated to follow requirements that directly conflict with Michigan law. Title 10 imposes obligations on the department that we have seen in recent memory are at odds with the prevailing views of the majority of residents of this county. The obligations of Title 10.
Folks, please stop.
So, Madam Chair, I base this upon actions that have been taken, at various levels by government officials. We determined that the material that was presented at the teen clinic to minors was inappropriate, right? By the same vein, that same material essentially has to be offered to children at the teen clinic as a condition of meeting these grant requirements. We must offer sexually explicit material of that nature for educational purposes in the context of Title 10. It's a requirement. The reason we had those materials to begin with was because they were developed for use in the Title 10 clinic. So I have grave concerns with the fact that if we do choose to continue with Title 10 funding, we are tying ourselves to a program that is proven to be very volatile, to have changing requirements, where the funding is not at all certain, where there could be legal challenges that put the funding in question, that put the requirements in question. If these new federal requirements are not overturned, if the RFK Jr. HHS priorities are implemented, it will require a radical redesign of our clinical services, which will further detract us from our core public health mission and return us to a much more primary care focus. I share the concerns about ensuring that no patient is left without these services. But I would say I have much more confidence than perhaps some of our staff members. And this has been demonstrated because of our common referral of these patients to the outside, right? Every time someone has a diagnosis of cervical cancer, we don't cure their cervical cancer. We send them outside. If we detect a breast lump, we don't excise the breast lump ourselves. We send them out into the community. All of the services that we provide here have a direct referral pathway to community providers. So I'm very confident that the overwhelming majority of these services will be provided within the community. The question before us is, do we tie ourselves to this very unreliable, volatile funding stream, thus forcing our hand on key staffing and budgetary decisions, which will impede our desired progress towards refocusing the department towards our core public health goals?
Stop, please. Jeff, if I could ask,
And one other point, a beautiful thing about offering Title X services in public health is that we are not seeing the lion's share of clients in our building. So we do have an opportunity, or staff has an opportunity to spend more quality time with clients and discover cancers or other lifestyle factors that might put them at risk and give them referrals to other things as well.
If I can just correct myself, 30% are LARCs, sorry. So, yeah, the long-acting reversible contraceptive.
So Amy, real quick before Jeff steps up, how many clients would be affected after September 30th with LARCs or Depo or anything else? How many, what is the
So-
number of that client that we
So
we would need to reallocate, or we would need to find care if we did not choose
would be
to do that?
240, roughly.
But I
It's a
don't,
rough number.
Right, so if you're looking overall, we're on track right now to, as we've increased last year, to see over 1,200 clients. We've
Oh.
increased, so those numbers will
400.
continue to increase as far as that goes. As far as if you're just asking just for LARCs, I would.
no, it
expect
would be
the
like, how
percentage
many
to remain-
clients would have to find other care is for the LARCs or whatever?
All of them that are.
So all 800? No,
Yes.
no, would have to find immediate, like, removal or replacement of those.
30% is what she's,
Okay.
so
That's.
Right.
On
So then we
1200,
would have
that'd
to
be-
develop a schedule where we could get clients in to expedite their care before we close, to reduce any gap in being able to access another provider to handle those prior to. So we would certainly need time to plan that and contact clients to kind of take care of them as best we can before there's a lapse, maybe
then-
to when they can access another provider for removal or, yeah.
And then what you're saying is you would have to do that before September 30th.
That would be ideal, just to ensure care, continuity of care as best we can
And
with a
that-
referral.
Yeah, it would only be mostly for the implant clients that would be coming due for removal. So it wouldn't be all of them, those that recently.
Oh, you
had
mean
it
like the
placed.
implant on, okay.
Yeah, yep, so
Okay.
next plan on. So if, I
Nexplanon.
know that's changed multiple. But yeah, so any that would be coming due for removal and then either switching to a different method or having a reinsertion done at that point would be primarily impacted. Anyone coming due for depot, but there is a time frame where they can get their subsequent injections there. But IUDs, again, anyone coming due for removal and possible reinsertion. So it wouldn't be the full 30% that would have to be addressed right away. But all of them essentially would have to be matched.
No, I understand all of them essentially, but I was looking more for immediately
Immediate needs.
rush. Like, what would that do for the nursing staff? Like, what are you guys looking at? Like, are you gonna have to get like 200 people in 2 months?
So again, I
Or what is
haven't
that
looked
looking like?
at a thorough financial or staffing analysis and patient census and determined each date. I mean, I'm certainly
Sorry, I'm
going to shift.
I'm a
gears if
numbers person.
necessary
No, I'm
and
just a numbers person,
absolutely do
Amy, so that helps me to understand.
Right.
No, it's a good question. Sorry, Amy.
No, you're good.
But when our full-time practitioner was leaving, we looked at that to see if, there was a huge number that needed to get in for a method change even before she left. So we had pulled from March through or to September 1st. And I believe there were only 19 clients.
Okay, that
who
helps me
had-
better. Thank you.
Yeah.
Okay. So we could look at maybe 50 before December is what you're saying? Okay. No, it just helps me to understand.
No, that's important, continuity of care and
yes.
linking everyone that we possibly can
Absolutely.
to a provider that would be available to see them, with their insurance status. Such.
Okay, if you guys could just hold out for 1 second, and then we'll let Jeff take a couple of questions. Could you just run the numbers for us? So
Okay.
is this program, are we in the red in this program?
Yeah, so as we said, with the revised
Funding.
funding amount, it runs at a wash, as do all of our programs. We're not in the business to turn a profit, right? So we receive about $500,000 a year between grants and insurance, the self-pay from the clients who can come in and pay some fees, as well as we bill both Medicaid and commercial insurance provide factor. So the whole group all adds up to support the core expenses, which is a large part is the wages and fringes, but then we have between $60,000 and $80,000 a year in supplies. And as Liz said, our cost for those is less than what can be found out. So while 80 grand may seem like a lot, it's going to be more in the private sector. So it is a complex financial equation. And then once a year, which I just did at the end of May, we apply for Medicaid full cost. reimbursement. And the staff helps me prepare encounter counts, and we report off of that to, and then they assess what our reimbursement rate is. So the FMAT rate is 90%. And then our local amount is the 10% remaining, but that 10% local match is not county dollars. It's a mix of state funded grants. It's a mix of commercial insurances. I can't include the Medicaid amounts because that's a federal program, and then it includes the self-pay. So the county does not need to provide 10% itself. We just have to ensure that among all the other sources of funds, we hit that 10% amount. And then based on all of the claims and grants and amounts we get, they come back with us at the end of the year, and it takes them months to a year to give us the final amount. And so Medicaid full cost is a year behind in terms of
Reimbursement.
right. And when we saw the patients. But the nice thing is they do give it to us as an interim quarter the payment. But Medicaid full cost is more than just the Title 10. Title 10 is one of 5 groups. So we will still have some aspect of that will come into the county, but we do lose some. One of the groups is clinics as well, so we haven't lost off of those encounter claims, but as we reshape the priorities of the county, it will change our funding as a whole. So, and it's something that may lag 6 months to 18 months post changes.
Can I say something?
Yeah.
Just to, I mean, regardless of what you think of the money being well spent or not, we budget pretty much neutral for everything. We're not for profit, and we will typically come in a couple thousand red, couple thousand black on different programs. But if you look historically since I've been here in 2011, our department has never run a deficit budget. Never. We've always been on the good end to the point where the county commissioners took fund balance from us, from our Medicaid full cost reimbursement to the tune of $3 million a couple years ago. So as far as finance wise, overall, without all the details, we are fine to run the programs we are doing. There's no projected problems or deficits at this point. So this decision really shouldn't be wrapped around funding.
Right, yeah. But, where I was leading with this is, does that have as you decreased, clinical services, does that affect our Medicaid reimbursement?
Sure.
It's
based on
right.
number of.
It's based on numbers of encounters totally.
That will be at this point.
So we're going to
report
take
once
out
a year.
1,200 encounters, let's say. That's what we're on track for. And so that's going to affect our overall reimbursement.
It will.
Okay,
It will.
thank you.
Adding on to that, I know, I'm sorry, speaking out of turn, would
You're
be,
good.
remember also, we decreased the number of encounters by eliminating our adolescent health centers.
Right.
That will impact us, and those impacts will feel next year. And then this decision would be on top of that as well. And like Jeff's saying, he can't estimate what
Right.
that would be because there's all different percentages and formulations depending on the type of service that you.
Right. Okay, thank you. Thank you, Jeff.
The Anyone else?
Commissioner Rushing, I know you had some questions. Paul, you had one more question for Amy and Rebecca, right?
Yeah, it was just a clarification.
Okay. I think we're good with you for now. Thank you. Welcome back. Go ahead, Paul.
Oh, no, what Joseph had just brought up in regards to the, I missed what you said about the consent and with parents and stuff like that in regards. Can you reiterate that?
So when you look at what we term and as confidential, if you will, we're talking about minors.
Yep.
Then that seek birth control
Okay,
would be less than 2% of that
Okay.
number that
got it.
of our clients.
Okay.
Commissioner Rushing.
Awful lot to digest today. And to make a decision today to end title fund, I can't say I'd support it, but you guys get to make that decision. The 2026 funding from estimates is 500,000. I don't know what 2027 is going to bring. If that's going to be the same amount or less, that depends on the federal funding. And if you follow what the federal government is currently doing, potentially they're going to gut Title 10 anyways. So the money might not be available. So this might be a moot point. I think whatever the time frame is, and I know you mentioned it, potentially a conflict of law with the Michigan state law and the federal of what we're doing, I think corporate counsel should make a decision on that. Because if we are in conflict of law, we should definitely stop it. If we're not, potentially continue. I am concerned with the confidentiality that parents are not being informed. I think that's a huge concern for parents. Whatever side you're on, you should know what your kids are doing. So I think you've raised a lot more questions today than what you can actually, I don't think you should make a decision. That's my opinion.
I would agree.
And whether it's by next month or the following month, and Dr. Nevin's got to do what he believes he has to do, but potentially 3 months, get all the questions that you possibly have. You guys do your homework because you weren't prepared, the finances and all that. Get you guys the information to where you can make a logical decision. I don't think eliminating today would be the correct decision in the best interest. And I think it'd be a detriment to the residents if we just eliminated it.
I agree.
So, Madam Chair, I can address the legal question that Commissioner Rushing had. So it's a longstanding principle that when there is a federal regulation that is, in this particular case, it's applied voluntarily to voluntary grant recipients, that supersedes any state law, right? It's a concept of federal supremacy. So federal supremacy is what essentially neutralizes or avoids state law, which would otherwise be in effect. So, for example, an encounter that a clinician could voluntarily disclose at their discretion to a parent at the teen clinic, here we would have our hands tied by Title 10. I've had longstanding concerns with this particular supremacy aspect of Title 10 funding. And to reiterate the question at hand here, we are behind on necessary staffing decisions. Continued eligibility for this program will depend upon us demonstrating that we can find and have a qualified full-time provider to provide these services. I have significant doubts about whether we are going to be able to find a qualified provider, not to provide these services on a case-by-case basis, but whether we are going to be able to legally meet the requirements of Title 10. And if we don't make a decision in this regard, we are going to be choosing to not rely upon potentially more stable, reliable, secure forms of funding and to make staffing decisions so that we can meet our core public health clinical services. In other words, I believe that a decision to not discontinue Title 10 funding and to continue to rely upon Title 10 funding introduces significant uncertainties into our practices going forward. So I would just like to be on record as saying I have concerns we may need to discontinue several services as a result of a failure to make a clear decision today.
Okay, duly noted.
Monica, may I ask one more
Yep,
question?
absolutely.
Liz, since looking at all this Title 10 funding, they are looking at potentially seriously changing it or eliminating how that is. have you at the health department started looking at how the services might change even if we try to maintain this and the services were essentially eliminated? or
Right,
greatly
and,
decreased?
so it's the
What
ti-
is your contingent plan if we continue, but the funding's not there, essentially?
well, I would question, about the funding. I think it's the time of year where, funding threats are made at all levels. You know, what's that?
Okay.
But what I'm going to say is that this program's been here for 50 years. There may be some changes within it. Historically, I have worked as nursing director through some previous changes, which I think were only maybe 3 or 4 years ago, and the staff had to implement them. So different changes came down within Title X that we had to implement within the program. You just do that. Have we looked? I would defer back to Amy and Rebecca. They've looked very closely at changes coming, more family-centered care, reproductive health, those kind of things. And I'll let them speak to it, but they were quite excited about those changes, to be honest. That may be coming within the program, not eliminating the program, but the changes within Title X that HHS is suggesting.
Yes, I was very hopeful that, and optimistic that some of these changes actually seem to align better with the board's express direction for the community. They do include body awareness, consent, refusal skills, natural family planning, fertility awareness methods, and body literacy. Also increased parental involvement where appropriate. So fiscal year 27 seems to better align with some of the concerns with the program itself.
And regarding the operation of our core services, we have continually met and exceeded all minimum program requirements during accreditation cycles for all of our core programs, in addition to running a rather successful Title X clinic.
So, Madam Chair, because we're discussing the potential changes to these requirements under Title X, it's entirely possible that the changes that are going to be imposed upon us by these new federal regulations will result in our having to make dramatic changes to the clinical practices in this program, which will lead us very far away from our core public health mission. The new Title X program, arguably, it's designed for two purposes. One, to facilitate conservative-leaning primary care clinics that would have otherwise not wanted to participate in Title X to avail themselves of this funding to pursue, very conservative-leaning policies. Or the other potential motivation of the federal government might be to make the program so odious to most typical subrecipient grantees that they simply choose not to accept the funding. And again, Planned Parenthood several years ago, they were unhappy with some of the grant requirement changes, and they elected to discontinue their reliance upon Title X funding. This is a very, very unstable footing for us to base our core services on. I would just like to, again, go on record as saying, I oppose and have significant concerns with our basing our core public health, STI prevention and treatment functions, which can be performed very efficiently with a minimum of staff, on this very volatile, ever-changing, uncertain federal funding stream. I believe that if we do not extricate ourselves from this increasingly volatile program, that we will face problems in the near term.
Does anybody else have any other questions? Okay. Liz, you're up.
That was so long. I'm sorry. I got wrapped up in that and I have to give a report. I'm gonna, let me see. I was prepared to talk about kindergarten oral health assessment, but I'll give my
Yes.
report first.
Okay.
on that.
Thank you, ladies, by the way.
I'll be brief. As you know, the written report is within your packet. I wanted you to know that the county audit is still ongoing. Jeff's still working closely on that. That's moving forward. We do intend to still bring a budget overview. One of my goals was to continue the education of our advisory board on our budget, and Jeff and I have talked about doing that. So hopefully next month, if there's room within the agenda, we can do that. The division directors, recently, we have reevaluated our manning table there. So what we're doing is looking at that manning table. Those are our list of positions for those who don't know that. So that's all the positions available to the health department, part-time and full-time. And we had to reevaluate that, and for financial purposes, there was a lot of openings that looking at will not be filled or continue to be filled. And that's just based on moving to the new building, efficiencies put in, some of the programmatic changes over the last year or two. And so we have decreased that down. So from 91 full-time employees to 76 on the manning table, 25 part-time down to 22. Some of those positions are open, and we leave them open for continuity of operations should something happen where we have to move individuals around or hire. That would be something that I wouldn't have to go to the Board of Commissioners for approval for a manning table change. So those are different. And we spent some time doing that, and directors did a great job at looking strategically at what our needs are now.
What were the part-time numbers? I'm sorry.
We had 25 available positions down to 22.
22, okay.
Mhm. Yeah. Let's see. I think that's about it from the written reports, unless there is additional questions. Then I'll get into kindergarten. Yep, ready? So, as you know, this memo was prepared by the nursing division. We made some changes. We have the kindergarten oral health assessment program. By law, we have to implement a program here through our health department in St. Clair County. We're fulfilling that requirement by a contract with Smiles on Wheels. You can remember that. That comes up about September, where we have to renew that contract or choose to do something different. If we're going to choose to do something different, we need to make a decision pretty quickly moving forward. So this was a summary, a background, what we're doing currently with Smiles on Wheels. We also gave you the outcomes for the last year. Things slowed down now that school is not in attendance. So you'll see there was 373 screenings done. That was an increase from the previous year at 291. You also see what Smiles on Wheels was actually seeing as they assess those students there. Also, if you remember, we went to I believe it was this advisory board and the Board of Commissioners wanted to do a opt-in there. We implemented that this year. We were able to work with Smiles on Wheels. They were very willing to do what we needed to continue the program. So that has worked out. Additionally, Amy and Rebecca have worked very closely with Port Huron area schools and found a way to assess students who are getting in to kindergarten at their vision and hearing screens, right? At their kindergarten roundups. Right, so that way not going into the schools, disrupting any services there. So that was a plus there as well. So on the opposite side, something other health departments do and could consider is hiring their own dental hygienist or professional. That's done in other counties. We broke that down here for you to consider. My recommendation, and I think from nursing division, Dr. Nevin agreed, was that we continue on with Smiles on Wheels as is, just work to get those case numbers continually growing, continue the relationship. I think it's, in my opinion, far too soon to cut that off before we really reach where we could be. So just wanted to get consensus from the board on that before we put that contract in front of the Board of Commissioners.
Rebecca, I thought you did a very excellent job
Yeah.
with the presentation. And the fact that you found a way through Port Huron. Great job. Great job.
Right. Right. I mean, working creatively with our partners, that's what they do best. And Smiles on Wheels was agreeable to something like that. And I know they also have put together a proposal to potentially have Smiles on Wheels here at our building. We do a lot of vision and hearing screenings. It's very busy through mid-August to beginning of September for those who have missed the screen to get into kindergarten. So potentially we could have them here doing that, catching up a lot of kids there.
Very good. Anybody have any questions on that? Anybody have any opposition to continuing with Smiles on Wheels? I don't think we need a motion. We've already approved it. I mean, it's not before us for a new contract. So,
No, there will be a new contract, right, Greg?
yeah,
Probably September,
it's a
August?
Board of Commissioners approval.
Right, so you would see it on that Board of Commissioner agenda.
Okay, is that all you have?
That is all I have.
Do we have anything from members?
Just as a quick thing, Monica, I know there's concerns overall about the Title X. I want to just reassure people, we're on the board, we're not trying to just make everybody miserable here in St. Clair County. That's not what we want. However, I do want to let people know that 50% of all pregnancies overall are unplanned. And even if you were to look at abortion numbers, 50% of those people are also already on birth control. That doesn't necessarily affect what we do here today, but just so you guys, just so the public knows, birth control doesn't stop abortions.
Okay.
It's still, abortions still happen when you're on a birth control. That's all I wanted to say about that.
Okay, anybody have anything else?
I know a couple, no, the only thing I was gonna ask, was there any movement on, I know a couple meetings ago, we talked about potentially looking for a PA, or I think Leanne, you had even said if we couldn't find a PA, you know, an NP or something, has there been any movement on staffing with any of that, or no?
That I would say is, Greg can add on to this as well, that is in the hands of county administration at this
okay.
point.
Okay.
I know, I have some concerns, I would say, with all these potential moving parts, right? And how we fund that position.
Okay.
Also, a concern just of optics of hiring on a additional full-time person, and potentially laying off others.
Sure.
That worries me as director.
Thank you.
So, Madam Chair, if I could, we are essentially stuck in making any sort of hiring decisions in sorting out the longstanding issues regarding oversight of the department. This is all waiting for a decision on what to do with the need to replace our full-time clinician. One of the primary reason, well, not the primary reason, but reason number one in the memo I provided is our near-term staffing needs force us to make a deliberate decision about the future nature of our clinical staff. We need to act now. We are already late in doing so. When we discussed this 2 months ago, we had anticipated no later than today, we have a job description posted, we make a decision on a clinician to hire. We have one part-time clinician. That's it. 3 days a week. So I am going to have to be coming into the health department to provide necessary clinical oversight on days that our clinician is not here. I'm not going to be able to do the Title X services. That's not my job. I'm not an obstetrician gynecologist. I'm a preventive medicine physician. In order for us to meet the Title X requirements, we need to hire a full-time staff member, likely, according to the grant requirements, specifically for nothing but Title X. It is, again, not certain that we are going to be able to do that in the near term. So I anticipate we will be out of compliance with our grant before the end of the fiscal year, because we lose our one remaining full-time nurse practitioner with the shift to teen health. We've known this for months, right? Which is why we made the recommendations we did. realistically, I don't think we're going to hire someone to this position in the near term. We may be lucky, get someone who's fully qualified. And there is still the outstanding issue that I need a deputy. If the longstanding concerns about the oversight and management of the department are going to be satisfactorily addressed to our mutual satisfaction, a non-negotiable condition of mine is that I have a deputy who represents me, who reports to me, who's on site 5 days a week. It's a non-negotiable condition for me. And there are many reasons for this, and I believe the commissioners and
Please.
One option is that my position be converted to full-time. That is as one option to address the lack of a deputy, right? If I'm to have representation at the health department 5 days a week, then I can provide that myself. There will be a significant expense incurred by our doing that to the county because I bill twice as much as our nurse practitioners do. And that will raise the question of, well, why do we have two full-time people overseeing the department when we could have one and we did have one, right? And the compromise that I understand had been reached was that I would remain part-time and have a full-time deputy representing me, reporting to me, and also providing core primary or core public health clinical services under my direction. One possibility, which I think may work, but this is not ideal, is if I can find a qualified candidate to serve as deputy medical director, they may be able to do some continued Title X work, and then our nurse practitioner can do the remainder of that public health work. Title X work. I don't know if that is going to be considered consistent with the grant requirements. What I believe is likely is that we essentially have a choice between hiring my deputy to pursue our core public health functions or sacrificing the deputy position, leading to a continuation of these longstanding governance concerns that we've all had. Again, the deputy was the solution to these longstanding governance concerns, essentially sacrificing that solution in favor of continued Title X operation under a full-time nurse practitioner. In my opinion, this would be less than ideal, and it would perpetuate the problems that we are all too familiar with. The deputy medical director position was the solution proposed for these problems.
I would like to see Dr. Nevin get his full-time deputy director. We all voted on this. It was unanimous. And we were told that it was budget neutral 2 months ago.
So with the Title X funding, so.
I'd like to see him, you know,
Okay.
everybody, from what I understand from talking to people, you know, everybody has their assistants, you know, Tom Hall's looking for an assistant. The nurses, your nursing
Mhm.
heads have their assistants. Of course, the medical director, in my opinion, would need an assistant too. So, for what it's worth.
Is there not a way to combine those two things?
Yeah, I think that was, that was the original thought, was using Title X dollars, leaving our part-time nurse practitioner. So you got to back way up and go way upstream. We have a part-time nurse practitioner because we moved her from Yale. Okay. Then we also had a full-time being paid out of Title X. We paid them both out of Title X. So, okay. So we still have our part-time. Thinking creatively was that we could use some Title X dollars and some additional dollars for a full-time person and split those duties a little bit. But with the Title X proposal that's here, I think you send us all back to the drawing board a little bit on how we could do that.
Madam Chair, there are genuine concerns about whether we can legally use Title X funds to fund activities which are not Title X activities.
Right, I definitely am not proposing that this person would back up Liz Sigafus 2 days a week and maybe other duties with Dr. Nevin 3 days a week when he is not in the office, or the one day here when, you know, and supplement that work. Oh. Correct. Thank you. You're right. So what we do is, a lot of our nursing division staff, many staff, we do a time tracking when we get paid. You have to do it every 2 weeks. And there's program codes that you use. And many of them, it's not just 7 days to one program code. It is broken down per day. If you're doing HIV, STD, that's one thing. Are you doing immunizations? Are you doing Title X work? And then Jeff actually has to break that out into that person's per hour pay. So there is a way to creatively think of this, and I appreciate your comments, Dawn.
Yeah, Madam Chair, as I mentioned in my comments, that was one solution that I proposed.
Great.
That rather than bind our hands and exclude the recommendations of the Health Advisory Board to provide me with a deputy, thus perpetuating the ongoing governance issues which we're all too familiar with, the agreed upon solution, the deputy position, potentially, if we can get all these details sorted out, would be for the deputy to provide fractional coverage of ongoing Title X services under an assumption that we do renew the grant and that grant funding remains available, and that they be able to devote 3 days a week, if my math is correct, roughly, to core public health, clinical, and deputy-related activities. That is, I think, within the realm of possibility. I don't know if that will work out, but I would agree it may be worth a try. Fundamentally, the problem is we must make a decision today on what we do in this regard. We need to begin hiring someone now. And I question whether we can find a qualified candidate who would be interested in and have the necessary skills and motivation to provide the necessary deputy clinical skills and deputy activities, and also be interested in and willing and trained to provide these Title X services. It may be possible, we may be able to shift some of the procedural care to when Liz is working, and then non-procedural care may be able to be provided on those days that the deputy is filling in for Title X. That may very well work, but it would introduce additional challenges to the hiring process that wouldn't be there if I could promise a potential candidate, you're not going to do contraception, right? Telling a clinician you're going to do contraceptive services limits the pool of available candidates for religious and moral and ethical reasons. We may be able to find someone, but it may take some time. And again, my concern is that unless we make a clear decision to extricate ourselves from Title X today, there are going to be delays, there are going to be gaps, there's going to be problems in the near term.
So I would please, you had an opportunity to speak during public comment. This is now the board's time. I personally would welcome that opportunity to try and hire somebody on that basis and attempt that first before we just axe an entire program. I think that that's a plausible solution. We don't know that we can't hire somebody if we don't try to hire them. So that I would fully support doing that and continuing with Title X.
Yeah, you guys can work more than capable, working out schematics of getting this done and continuing services, I believe. You know, we're already working on it at the commissioner level for the deputy as a recommendation from the advisory board. That may very well be on our agenda for tomorrow night, but we're working on it. We're gonna get that done one way or the other. So you guys can work out the schematics. There's an awful lot of conversations. I believe you can work together and make sure we can continue with the services that we're given. And wherever you go with the Title X, got so many more questions today. And I don't think motion's in order, but that's up to you guys. Either deny it or go forward with it. If it's gonna be denied, then I think that's something that's gonna be a detriment if you try to get it corrected as we go forward. So let us see if the county commissioners can get your position as deputy filled. And then you guys work out the schematics, making sure that we can continue what we're doing. You guys have the key.
Thank you. Anything further from members?
I just want to say, I mean, there are some aspects of Title X that I don't agree with, like the parent,
I
not
share that
informing
concern,
the parent.
right? I share that
Yes, yes. But it is a lot to digest for today, to make a decision for today. This was a great conversation, amongst the board. I would support, attempting for the commissioners to try to hire a deputy position that can focus, on the assistance of Dr. Nevin, as well as maybe filling in some of those gaps with the Title X services while we get our questions answered and, maybe consider for, further discussion next month on the Title X. And maybe with those numbers that Leanne had asked for next month.
And Madam Chair, I would support that. That would be fine with me. My concern has been that our reliance upon this funding would interfere with our core public health mission. I recognize there's a lot to process. The primary staffing concern with a continuation of Title X funding would be whether we could find someone qualified who would want to come on board solely to provide Title X services. I think in the context of this debate and the controversy, I think it would be very difficult to actually recruit someone solely for what they might think would be a very short-term assignment to a family planning position in the department. That being said, I don't think we would have those concerns if we specify this is a candidate who works for Dr. Nevin in the title of deputy. They assist in providing Title X services for the time being, with the full understanding that as we consider this issue more, and as the federal picture becomes clearer, we may or may not choose to continue it. I think it would be a lot easier to find a qualified candidate like that. I do have concerns about funding. I do have concerns about sustainability of this funding going forward. I think that by tying ourselves to Title X, we are introducing significant uncertainty, which is unnecessary. We're introducing significant cost inefficiencies. We are delaying a necessary reorganization of staffing at the department as we move away from a primary clinical model to a primary public health model. But all that being said, I would be satisfied today with continuing the status quo with decisive action on the part of the board and the department to hire me the deputy that we have agreed I need.
Okay. Is everyone good with that?
She needs a deputy.
Yes.
We voted on that. I don't think anybody disagrees on that.
Yeah, the same.
Is there a motion to adjourn?
So moved.
Hey, at 11:54, is there support?
Support.
Take Leanne.
Well, Amy, you get your
All in favor?
Title X.
Aye.
Aye.
We are adjourned. Thank you all for coming.